You are the first person to join the conference.
We're not going to have any affiliates connected.
No, I just wondered, whatever is fine. I've given talks to 3 people in the past, but
This year to see if
yeah, and I don't know if that's going to get discussed. I should have talked to Karen. I mean, I think if they're all recorded and people are have access to the IHI, and we were just talking about the Lean Six Sigma that a lot of people are doing, I think this is superfluous. Now, when it was discussed the last time I was on GME, there seemed to be a couple of the residents who liked the interaction, but sort of a lot of effort if there's any audience.
and lately, like the ones they want to sit there.
So I don't know about the surgery people. I think are all.
Does need to be have a conversation about.
Yeah. Because there may be something that we're not covering that maybe we could just do 1 or 2 or something. But
Right. Right. That's
I think I missed some bad stuff too. Yeah. You're in the right place.
Did you sign it?
I mean, I got the email, I looked at the, yeah.
give them, so it's just 12, right? I'll give a couple more minutes. Yeah. I'll give them a few more minutes. You guys from medicine, psych, what are you from? ENT? Well, you're welcome. Are there other people standing out there? No? Okay. Well, we may as well get started. It's a small crowd, but you're all very welcome. So my name is Hilary Samphy. I'm Vice Chair for Education in the Department of Surgery. And this is one of a series of lectures on various patient safety issues. And what we're going to talk about today will be some specific situations in which error can occur and some strategies for addressing these. So just beginning with a couple of quotations from people who are involved in healthcare. And this is the first one from Don Berwick, who's the director of the Centers for Medicare and Medicaid. I've climbed Mount Rainier 5 times. Each time I made that tough trek, my risk of dying was about 100 times smaller than the risk I face on the operating table. And this one is from anesthesiology, from an anesthetist who wrote an editorial some years ago. More than 40 times a week in the United States, a surgeon cuts into a patient or an anesthesiologist places a nerve block only to realize that the scalpel or needle belonged somewhere else. So there's been a sense for decades that medicine is not a perfect science and that mistakes are made. The culture has always been perhaps not to talk about this openly, but that is changing. So while we've had this sense that medicine was not perfect, often patient perception was very, very different. If you were to ask most patients which did they fear more, coming into hospital or flying, most people would probably be concerned that the risk of dying was greater in an airline accident. So who can tell me what's your risk of dying in an airline accident? Can anyone give me a number? 1 in 10, 1 in 1,000, 1 in a million? 1 in a million? Up, down, any other advances? It's actually 1 in 8 million. And you would have to, the average person would have to fly around the clock for more than 438 years before being involved in a fatal crash. Or to be the equivalent of the number of patients who die each year as a result of medical errors, probably need to have 1 or 2, depending on the size, airliners crash every day. So since the publication of To Err is Human over a decade ago, there has been a much greater, not just awareness, but openness and a sense of a need for accountability when in terms of medical error. Because now we know that somewhere up to 100,000 deaths may occur each year as a result of medical error. It's not always clear what's directly or indirectly as a result of error. We do know that in that 3-year period, 2004 to 2006, there were almost 250,000 deaths in U.S. Medicare patient population. So that's in that slightly older population. So the number of deaths from medical error is probably more than the number of people who die each year in road traffic accidents from breast cancer or from AIDS combined. Yet previously, all of these certainly received far greater attention. So just to revise a couple of the terms that we use when we talk about error. So error is unintentionally doing the wrong thing. And errors can be slips, they can be lapses, or they can be mistakes. Anyone want to volunteer the difference? Nope, no volunteers? Well, a slip is where you intend doing the right thing, but just make a mistake. So you want to dial a number, and you dial the wrong number. That's a slip. A lapse involves an error, an omission, something that you forget. So you know there's a number of steps that you have to take, but you unintentionally omit one of those steps. So for example, you're making coffee in the morning, you forget to put coffee in the percolator. So that's a lapse. It's something that's forgotten. A mistake means doing the wrong thing, but not knowing it is the wrong thing. So it's unintentionally doing the wrong thing. So those people who spend a lot of time analyzing errors look quite differently at slips, lapses, and mistakes, and I'll come back to that just at the very end. The other form of error is a violation, and the difference is important because a violation is a deliberate deviation from the accepted protocol or the accepted standard of care. And unlike errors, a violation probably requires some at least stern remedial action, if not actually punitive action, because it is a deliberate deviation. Just to remind you of 2 other points. Patient injury can occur in the form of a complication without there being an error. So sometimes patients get infections, they get complications, and there is not an error involved. And this is important in terms of how we communicate with patients. And secondly, many errors occur that have no consequence because they're recognized before harm occurs. And these are what we call the near misses. And these are important because studying those near misses helps us pick up gaps in the system and come up with protocols to prevent the actual crash or the actual accident. So you've seen the Swiss Cheal model many, many times. And what this tells us is that there's a risk, there's a hazard, and when you have a perfect storm, when there are gaps in the system, the safety nets are not in place, a protocol is violated, that's when injury occurs. And some of the holes in the system are due to active failures, and active failures are what we call the slips, the lapses, the mistakes. These are the human errors. The other holes are due to latent conditions, and these are organizational lapses or systems problems. So maybe that the right IT technology is not in place, there aren't safety nets in the computer to pick up allergies, etc. And the way to avoid going from a hazard to a loss or to an injury is to make sure you have successive layers of defense, barriers, and safeguards in place. Okay, so objectives for today will be to talk about potential causes of error and strategies. And what I'm going to focus on are errors that result largely from patient misidentification in some way or another. And specifically, I'll say a little bit about wrong site operations and procedures and medication errors. So on this slide, you're looking at a long list of never events. And never events are events that, by definition, should never occur to a patient while they're in the hospital. And there's a number of government organizations that have come up with these lists. JACO have the list, Medicare has a list. Not only are these lists important because these are events that should not happen to the patient because they have an adverse outcome, but they're important because some of the funding agencies will not reimburse if one of these events occur. So if a patient has a prolonged stay as a result of a retained foreign object, for example, the hospital may not get reimbursed for their patient care. So one way to get the attention of our hospital administrators and our leaders is to hit them where it hurts, i.e. to undercut their funding. So this might seem to be quite a diverse list, and in many ways it is, but it does have some commonality as you look through it. So a lot of these pertain to misidentification of patient or some procedure pertaining to the patient, and hence the focus of what we're going to talk about today. If there's any questions at any time, just stop me. Alrighty? So what about wrong side surgery and wrong side procedures? Wrong side occurrences are not as unusual as you might like to think. They're about 2,500 a year, or 1 in 21,000 procedures or operations. Now, wrong side can refer to either doing a procedure or an operation on the wrong side of the patient, on the wrong part of the patient. It can be the right patient but the wrong procedure, or the right procedure, wrong patient. Most commonly, these are wrong side operations or wrong side procedures. And when you look at these, the incidence by specialty, the highest incidence occurs in orthopedic general surgery and in anesthesiology. And the highest incidence will occur in those situations in which there's often a choice of side. Coming back to what I said earlier, that most of these will occur where you have wrong side versus wrong part, or wrong patient or wrong procedure. And it's been estimated for orthopedic surgery that 1 in 4 orthopedic surgeons will have a wrong site event in the course of a 35-year career. So not that unusual. And unfortunately, some of our information about wrong side surgery gets picked up by the media in a way that is not helpful. We often hear those jokes about surgeons cutting off the wrong leg, but clearly this happens, and it's devastating for the patient. But we shouldn't forget that these events are also devastating for the healthcare provider. And that's not something I'm going to touch on very much today, but the fact that we now have a culture that is much more open, that has got away from that blame, is making it much easier also to provide support for somebody who, through human error, has some devastating consequence. And I hope if this happens to any of you, that you will have somewhere that you can go that's a safe place for you to talk about it. So what are the contributing factors? As you might expect, emergency cases top the list. And if there's an unusual time pressure, and this can be a time pressure because of the urgency of the operation, time pressure because you're trying to get through your list before all the nurses close down the ORs. It may be that you're working with a team of people with whom you're not familiar. You've got new equipment. You're in the middle of the night. It's not your usual nursing staff. It's not the usual circulator. It's not the usual anesthesiologist. If there are multiple surgeons, again, potential for error. A case that requires a change of teams, potential for error, or multiple procedures on the one patient. So all of these contribute to wrong side surgeries or procedures. But we're also talking about interventional radiology, anesthesiology. It is not just error in the operating room. These can happen in the endoscopy suite or anywhere else. So other risk factors pertain mostly to poor communication. So incomplete assessment of the patient in the medical record, or perhaps the medical record itself is incomplete, or the medical record is not available. If you're using a paper record, perhaps you don't have those outpatient notes to hand. Maybe staffing issues. Everybody's short-staffed in these days. People are rushed. They don't go through the normal guidelines, the normal checklist, the normal procedures. There may be some patient characteristics, as in a patient not able to verbalize the site or the exact procedure, a patient just not knowing or just giving misinformation Perhaps there's not a family member in the room to double check. There may be a language barrier. And often everybody's just not on the same page. So there may be a change in shifts. The staff have gone home. The night team of interns or residents have gone home. There hasn't been a good handover. The pre-op team is different from the operative team. And everyone's just not on the same page. There's not been there's been miscommunication, or maybe the order of the list gets changed, and maybe the carpal tunnel that you thought was going first is now going last. So again, everyone's just not fully aware of changes. There may be a failure to include the family when identifying the correct site. Handwriting may be illegible. Abbreviations may be illegible. Or the abbreviations may be used inappropriately, or the site may be marked in something that's not indelible. It gets washed off. So the strategies to prevent this are pretty much the reverse of all of the risk factors. So making sure that you use at least 2 patient identifiers, and this may be the patient's name, their date of birth, involve the patient and a family member with identifying the site. Also use a medical record and an X-ray if appropriate. Make sure that there's a good debrief with the team. If there's a change in personnel, repeat the timeout. And as far as possible, get away from handwritten orders, verbal orders, and go with something that is legible. All right, so we're going to move in now to talk a little bit about medication error, moving away from wrong site. And when we talk about medication, I'm including pretty much anything that's given to the patient. It might be IV fluids, it might be contrast by IV or oral contrast for some radiological study. It could be an enema, it might be barium. Let's consider all of those. Now, there is a classification of error that goes A through I, where A is the most benign, and A is not, you might say it's not really an error. Its circumstances exist for potential errors to occur. I think most of us would agree that if a patient comes into hospital and they're going to have a procedure, medication is prescribed, that potential exists. So the potential for error exists in every single patient. Next in line is the error occurs, but it doesn't reach the patient. So let's say by mistake, the pharmacy sends up Coumadin for a patient, but the nurse at the bedside realizes that patient shouldn't have Coumadin. So the error has occurred, but no harm. But it needs to be investigated to find out how the wrong medication came to the patient. Maybe the error was, maybe the patient got their Coumadin, but they were on Coumadin anyway, they just got it at the wrong time. It didn't cause harm. Perhaps the patient did have a slight overdose in Coumadin, so extra monitoring was required. Now we're moving into the slightly more serious classification, where the error caused some temporary harm, so some temporary elevation in PT beyond therapeutic levels, perhaps some intervention to reverse it, temporary harm with initial prolonged hospitalization, error resulting in potential patient harm, requiring an intervention to sustain the patient's life, and contributing to the patient's death. So again, a way to classify errors that occur with prescribing anything that is enters a patient's body cavity. So we're going to go through a case study right now. So this is a study. This case study is from the nursing literature. An attending MD tells a resident to give the patient free water, meaning let her drink water. Are any of you familiar with that expression, free water? No? Some people have heard it. As many of you know, I trained in Ireland, did a lot of my training in Ireland and the United Kingdom, and this is an expression that we would commonly use when we just mean let the patient have free fluids. We'd say, give them some free water. So the attending has given this instruction to the resident. The resident assumes that the attending means an IV and writes for water to be given IV. The new nurse can't find IV water, so she calls the pharmacy asking where they get IVs. The pharmacy doesn't question this and just says, sure, go to Central Supplies. So the nurse, being helpful, goes to Central Supplies and gets the water. Central Supplies don't ask why she bypassed pharmacy, and the water bag is clearly labeled water for irrigation. So this is something that was probably used for urology, perhaps after prostatectomies or in the operating room to wash out the abdomen. So the nurse gives the bag attaches it to the IV tubing, and she infuses 600 mils of free water. And later, a more experienced nurse notes that the patient is lethargic. She sees the bag of water, she removes it, and she calls the doctor. So what went wrong here? Where were the errors? Where could this have been picked up? This is the interactive part. And I'm going to have to ask you to speak up because this is being recorded. I'm sorry, a resident knowledge deficit? Okay. Anything else about the resident besides a knowledge deficit? So the attending gives the order, the resident fills it out. Okay, so it was a communication error. So it was an error in communication on the part of the attending for not clarifying what he or she meant. The resident misunderstood the order, but may have questioned the order and just been afraid to speak up, right? May have been afraid to question the attending, or may have been afraid to say, I don't understand this. How should I give it? So two potential errors there. The MD used an unfamiliar term, free water, when he meant let the patient drink water. And perhaps the resident either didn't know that there was a problem with ordering IV water, or else he thought perhaps this isn't right, but was afraid to speak up. Anything else any other points in the chain where this might have been picked up? Between the nurse and the pharmacist, okay, so the nurse tried to be helpful. She called the pharmacy. Can you be specific about what the nurse might have done differently when she spoke to the pharmacy? Okay, well, the pharmacist maybe should have questioned the nurse a little bit. So the first, I would say the nurse, she called the pharmacy, but she didn't ask who answered the phone. So it could have been the cleaning lady who answered the phone. It may have been a tech. So she may not have been actually speaking to the pharmacist. She didn't check who am I speaking to before she accepted the answer to the question as being appropriate. So she went and she tried to be helpful and she got the supplies. So the pharmacy tech who answered the phone didn't identify herself as a tech. She didn't ask the nurse why she was asking the question, didn't consider having a qualified pharmacist consult with her. And then the central supply staff didn't ask the nurse why pharmacy wasn't involved, and they just handed over the medication. So a lot of points coming back to our Swiss cheese model. This is a good example of where something falls through the cracks. So there was potential here to pick this up at several different points, and most of these errors pertained to communication or to, as well as to clearly identifying the site of what was required. Okay, so this was meant to be oral administration of fluids and not IV administration. So it came back to one of those errors that we talked about earlier, where the route of administration is not clearly identified to the patient or to the nurse. So, strategies to reduce medication errors in general, as well as possibly some will apply to the case I've just given, but many don't. So using sound medication reconciliation techniques, and often the patients come into, particularly the medical clinics, more so than the surgical clinics, have a long list of medications, and we just say, have any of your medications changed? It really is important that somebody, and it can be the nurse, if it's not, if physician goes through that list and says, are you still taking X amount of this? Are you still taking? Has the dosage changed? Have you any new medications? And it needs to be a thoughtful question, waiting for the answer, and not just a check, 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 as it often is. Avoid verbal orders except in emergency. Avoid using abbreviations. Make sure patients understand why they're on every medication, and the dosage, the potential interactions. Work as a team with pharmacists and nurses, and use special caution with some high-risk medications. And there's a category of medications that are called LASA medications, or look-alike, sound-alike. And if you Google that or go to that website, you'll be surprised at the list that comes up. I mean, this is something like Lasix, Losec, where the names just sound the same and they frequently get confused. And there has been a move in recent years to try and eliminate some of these, but there are a lot of barriers in place. And some of the barriers to eliminating these look-alike, sound-alike medications include an unwillingness on the part of prescribers to conform to using a limited formulary. So many hospitals have tried to limit the drugs that are available, both as a safety and a cost-saving measure, and often physicians, sometimes for very good reasons, want to stick to what they're familiar with and don't want to change. Some other barriers are language barriers among healthcare providers, the use of a brand name versus a proprietary name. And then industry often likes the fact that their product is associated with a particular type of brand name. I mean, think iPod, iPad, iPhone. They like the people to know these are the people making your drugs. So there's been an unwillingness on the part of industry to often eliminate those look-alike, sound-alike drugs. And then an unwillingness to invest in technology that picks up drug interactions and that asks the question, that links the drug to perhaps a patient diagnosis and says, do you really want to prescribe X for this condition? So again, many reasons why it's been difficult to implement the recommendations made about LASA medications. All right, so just a reminder of the JCO recommendations. They encourage using at least 2 patient identifiers, and institutionally that the patient ID system should be standardized within a healthcare department or within an institution. So, for example, using the same color wristbands for particular conditions, etc. And encouraging the patient not just to know their medications, but anytime you take a blood sample or any sample when the patient is conscious, have them involved in labeling them to make sure that the PAT specimens, etc., blood samples go to the lab with the correct name. All right, so we're going to move in now and talk a little bit about checklists. And there's been a lot of discussion recently about incorporating checklists, not just in the operating room, but in many other patient care areas. This is not rocket science. Checklists have been in place for decades in aviation. All of us use lists. We write out lists of tasks, we write out our shopping, we write out our laundry list, whatever it is, we all do it. But checklists have come into vogue for 2 reasons. One is a result of the book that was published by Atul Gawande, who's one of the safety gurus, and then the World Health Organization got on board with developing checklists for a number of specific situations. And this is a surgical one, which gives a pre-procedure, sign-in, time-out, sign-out list of steps that need to be, in which all the healthcare team should participate before the patient goes to sleep, pre, during, after, and then at sign-out. Do any of you use checklists? I know they're used in the operating room. Any other examples that you could have in healthcare settings? No? No? All right. So there have been a couple of studies. This one is probably the best known. It's the older one, in which 8 hospitals throughout the world instituted checklists for 6 safety measures in the operating room: airway assessment, pulse ox, IV access, appropriate antibiotics, identifying the patient, having that timeout, and then for the sponge count. And what they found in this one study was that the death rate decreased 100%, the surgical site infection and the unplanned reoperation rate decreased by 100%, and that all complications decreased 11 to 7%. And it didn't cost very much to implement it. It took a minute at the beginning of the case. There was no huge expense involved. All right, so now we'll see if we can go with the video.
Dr. Carter, excuse me. Everything okay? We are moving you. Where's Kurtzeg? Ready about that bag? Hands up. Let's go.
Sound okay?
Wish me luck, huh? Arm just fell asleep.
Stop being a baby.
Plus, I feel like I'm hanging out of this thing. Can someone cover up my crotch, please?
He's here.
We have a visitor. I don't remember being asked if Dr. Benton could scrub in for this.
I'm a friend of the patient. He asked if I would observe.
Uh-huh. Put him under. Let's do this.
Whoa, whoa. What about the checklist?
Excuse me.
Safe surgery checklist?
I've had 10 cases today, Doctor.
All the more reason to take the necessary precautions. It'll only take a minute.
1 minute.
John Carter here for a right cadaveric renal allograft.
Correct.
Does the patient have a known allergy?
No.
Does anesthesia anticipate a difficult airway?
No.
Is the risk of bleeding greater than 500 cc's?
I sure as hell hope not. Let's go. Put him under.
Whoa, 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 whoa. Everybody slow down. Now let's just take our time and introduce the room.
What's next? We all hold hands and sing Kumbaya?
Sheila Lane, scrub nurse.
Paula Cheney, circulating nurse.
Kay Schumacher, anesthesiologist.
Randall Okerman, chief surgical resident.
Ethan Dean, surgical intern.
Peter Benton, observing general surgeon. Any concerns from the surgical team?
Only that you're wasting my time.
Any nursing concerns?
We don't have any reperfusion solution.
We won't be needing it.
I'll have some sent up.
Were any antibiotics given in the last 60 minutes?
Just starting them now.
10 blade.
Okay, hold on. If you run the antibiotics prior to incision, you cut the risk of infection by half.
Dr. Benton, you're a guest here, and I don't like guests. As a friend of the patient, you're welcome to sit, observe, and shut up. 10 blade. TDS for the ureter.
Shouldn't it be pinking up by now?
What happened to sitting quietly in the corner, Dr. Benton?
No, seriously, shouldn't it be?
Sometimes it takes a minute.
I don't have parenchymal pulse.
Crap. We've got an arterial thrombosis. Reclamp and take down the sutures.
Satinsky, please. Where's the clot?
Renal arteries obstructing the blood flow. Gonna have to take it out and start all over again.
Problem solved. Flush with heparin, saline, and reperfusion solution.
Reperfusion solution?
We've got it. We're all set.
Oh, well, it's a good thing we just had some laying around, huh? How long did it take to get the reperfusion solution up from the pharmacy?
15 minutes.
What happens if you don't have the reperfusion solution?
You made your point, Doctor?
No, I disagree, Doctor. I think that this is an excellent teaching opportunity, though. You'd have had 15 minutes of warm ischemia, the organ would have taken a major blow, and there's a good chance we would have ended up with a non-functioning kidney. Wouldn't you agree, Doctor?
If we're all done teaching here, perhaps some of you would like to assist me in getting this kidney back into the patient's body.
Where do you get a copy of that checklist?
Now, people!
Okay, now, people. Oh,
Here, press for fentanyl.
okay.
Still here.
Had you seen that video before? No? Okay. So, comments on that video. Had you seen it before? Are you all too young for ER? All right, so a couple of things that could have been done better, obviously, in that video. Any comments on how either Benton or the team might have handled it a little differently? Other than the obvious. No comments? All right. Well, I think the point, was clearly made that the checklist was important. The kidney needed to be removed. For those of you that have not seen a kidney transplant, that meant reflushing it in order to get out the blood that would have accumulated in the kidney so that it could be reimplanted. The point was made that they did not have the solution without going through the checklist. I think Benton might have been more courteous when he came into the operating room as a guest and introduced himself. But when we look at checklists and ask how do they work, it's not just about checking the boxes and making sure you have the right things in place. That's obviously important. But the fact that you have that huddle or brief at the beginning is so important because it sets the tone for the entire case. And I think one of the lessons was that the tone was not set because it became confrontational when Benton asked about the checklist at the beginning. So I think that could have been handled a little better, though it was not the lesson. You may have noticed that they all introduced themselves again. It's all part of making sure that everyone knows their role, but also making people more comfortable to speak up if they have a concern. Discussing critical aspects of the case is also important, part of the checklist. And it also builds this sense that we're all a team, we're all in this together. So important beyond just checking boxes. There are some concerns with the checklist, that people then become mindless machines who do just check boxes. And if any of you use those pre-printed H&Ps in your clinic, you may often find yourself just checking boxes and not really thinking, heart, lungs, pulse, blood pressure, not really stopping to think, what does it mean? And there's this quotation, heads down on a checklist, unable to look out the windshield and cope with the real world ahead of them. So again, you have to be careful that if you are using a checklist, that you're actually thinking about what you're checking. Roadblocks to introducing a checklist mostly are on the part of surgeons, and this comes from our culture of being the captain of the ship and not working well in a more level hierarchy. So most blocks come from surgeons and from other physicians. Occasionally you'll get people who are just passive-aggressive and just don't participate. And we still have nurses who say they'd be hesitant to speak up if they saw a physician making a mistake. So we'll talk the next time more about communication, but just to touch on something for the sake of completeness, this is an article that was in the New England Journal of Medicine just 2 years ago about a patient case where a number of people had concerns about the treatment that a patient was receiving, but for various reasons chose not to speak up, and the patient had a bad outcome. So it's an informative case if you have time to read it. So hence we have our culture of speaking up, and we have the language that comes from the Team Steps curriculum that everybody uses is the 2-step, I'm concerned, I'm uncomfortable, this is a patient safety issue, and then repeating this if you don't get people's attention. Whatever language you use, everybody should know that once you speak up and say, time out, let's stop, let's think about this, that there is a patient safety concern and that it's not just somebody being difficult. So, by way of summary, we want to close all the holes in that Swiss cheese. And the strategies include team briefings, debriefings, appropriately sharing information, creating a culture where people are comfortable questioning what's being done, are not afraid to own up to an omission for fear of ridicule, making sure that you make sense of the orders you're giving. So where possible, instead of just saying, let's get that CT, you explain this is what we're looking for, so that whoever is carrying out the order will understand what has to be communicated back to you and whether or not it has to be communicated in a timely manner, or is it something that can wait till you come back up out of clinic or whatever, or the next day, or is it something that somebody has to know about in the middle of the night? Make sure if you're a team leader that you're managing the workload, that other people are not overworked, overburdened, that one person is not carrying the whole load for the team and somebody's not slacking. And if you see that somebody on your team is stressed, making sure that you address that. And making sure that you teach appropriately, not just teach the science of your specialty, but talking a little bit about errors and how these can be prevented with your team. So we talked at the beginning a little bit about lapses, skills, and errors can also fall into the category of errors that have to do with a skill that's lacking, or a rule that hasn't been obeyed, or where there's a deficit in knowledge. And prevention, if it's a slip or a lapse, prevention is just paying attention. And impediments to paying attention are exhaustion, fatigue, hungry, distraction, a rule-based error. Then you need to educate. There needs to be more critical thinking, more accountability. Knowledge-based, got to go read. And teach decision-making skills to your juniors. And often it's not so much decision-making that's needed as prioritizing. And I can't emphasize this enough. Speaking up if you don't understand the order. You know, many years ago, I had done a liver transplant on a patient, and I remember rounding in the ICU and telling the ICU resident to remove the Jackson Pratt drain. The resident communicated that to the medical student, who went in and pulled the T-tube by mistake, which was not desirable in a liver transplant patient the first day post-op. But again, I didn't make it clear. I should have taken the resident to the bedside and said, this is the Jackson Pratt and this is the T-tube and this is what you're going to pull. So making sure that your orders are clear and that everyone understands what has to be done. And don't forget HALT. If you're hungry, angry, late, you're tired, stop. Stop and think, and make sure that you're not too distracted to carry out your assigned tasks. All right, so any questions? Right, and I'm going to repeat that just because we're recording it. So the point is that sometimes common sense prevails, and I would absolutely agree with you. And it used to drive me crazy, again, when I was doing a liver transplant, somebody had to mark the liver on the right side, like, there's a liver on the other side. But it's about getting people into the habit of doing this every single time. So if you start saying, well, it's obvious that this patient only has one leg, so it's obvious we don't need to do it this time, then it becomes less of a habit and it is forgotten when it is essential. So I agree, at some point it gets to be, give me patience, let's just get on with it. But it just has to be done that way every time, or it's not done when it's important. Any other questions or comments? All right, thanks everyone.